Good evening. So my name is Shabnam, as Dr. Levine mentioned, and I'm one of the cancer counselors at the Perlmutter Cancer Center. This evening I'm going to just give a general overview about genetic counseling. Some people are aware of it, others are not, so it's just kind of a refresher for those who are not familiar with genetic counseling. And then just talk about hereditary cancer susceptibility and how it relates to gynecological cancers. So genetic counseling is the process of helping people understand and adapt to medical, psychological, and familial implications for genetic contribution to disease. Genetic counseling has been around for some time now, but the familiarity with it has evolved. And genetic counselors work in various settings, clinically and in industry, whether it's with a laboratory or testing companies. And then in prenatal preconception and adult genetics. Tonight's focus will be specifically around cancer. So the primary goal in a cancer genetic counseling session is really to identify individuals and families at increased risk for cancer for the purpose of promoting awareness, early detection, and also prevention when possible. Oops, sorry guys, the slides. We help interpret information, do personalized risk assessments based on medical and family histories, and provide education around inheritance, risk to family members, testing options, prevention, provide resources and psychosocial support in really difficult scenarios and settings, and also provide counseling to provide informed decision-making and adaptation to a risk or a potential diagnosis. Pretest counseling is something that I would suggest that all genetic counselors would agree is a really important aspect to genetic counseling because it provides a lot of information that many patients may not be aware of around the implications of genetic test results. So we generally go over the reason for the appointment. Again, take a medical and family history. The family history usually goes back 3 or 4 generations so that we can really get a clear picture of what we're seeing, not only on the paternal side, but the maternal side as well. And with that information, we can make a personalized risk assessment. We do run models to see what the probability would be of someone to test positive for BRCA gene, or in some other cases, Lynch syndrome, and other known cancer syndromes that have models available for testing. We do discuss testing options. They have grown over the years, so they've become a little bit more complex and complicated. So it's not as simple as just BRCA testing any longer, that's still available. So we do provide a little bit more groundwork about what are the options, and sometimes it can be pretty complex. And of course, really go over the risk, benefits, and the limitations of genetic testing. Genetic testing, unfortunately, isn't as perfect as we would like to think and doesn't always give us the answer that we're looking for. There's a lot of uncertainty and gray area, and our role is really to help guide patients with that information and review possible psychological aspects and also the implications for not only the patient themselves, but their family members. And of course, actually one other comment that comes up pretty frequently is around discrimination. So we do spend a good portion of our counseling around insurance laws, life insurance laws, and how it pertains to GINA, which is the Genetic Information Non-Discrimination Act, which was passed in 2008. I'm not going to spend too much time on that, but I can definitely answer any questions at the end if there are any specific ones related to it. Most of the cancer syndromes that we do see in clinic are going to be inherited in the autosomal dominant fashion, meaning that if we do identify a mutation or a change in any of the genes that we're testing for, there's a 50% chance that a first-degree relative will also screen positive. So that would be someone's parents, siblings, or children. And so that's a huge discussion that we have in the clinical realm, and also helps guide who the next person would be that we should offer testing to. And we consider that cascade testing. So it's kind of a downstream effect from the original person that we initially tested. So genetic testing, for the most part, is pretty simple. It can be a blood draw or spit, depending on preferences. But the way in which we do testing is a little bit more complex. We want to make sure that the information we're providing is most appropriate for the individual, but also the family members, and then we are actually ordering the right test. There are a lot of different tests available, and not all are created equal, and so we want to really make sure that what we're giving you is the most relevant. So typically with a cancer, in the cancer setting, we want to start with the individual who has a cancer diagnosis, and it's typically the person in the family who has the youngest or the most rare diagnosis in many cases. And then, and that's typically before an unaffected individual. If there is a known mutation in the family, then of course anyone who's affected or unaffected would qualify for testing, and that's an appropriate way to start. Individuals sometimes come to us for management decisions, whether it's to determine a type of chemotherapy or surgical intervention. And so in those cases, we have a diagnosis that we're working with and potentially a family history. And so we're able to provide testing and then impact the next steps in their treatment plan. In some cases, we are going to get healthy individuals who do not have cancer, and the best testable person in the family has passed away. An example of this could be a woman who has a mother who had ovarian cancer who's passed and never was able to have testing. In those cases, we obviously can offer genetic testing and counseling, but of course, we discuss the limitations in that circumstance. And there are many cases that genetic testing may not be appropriate because there is no risk really in the family history after we're able to take it. So we do have a lot of counseling in those circumstances as well, and explaining the benefits or limitations in those cases. So in a post-test session, we do provide risk management options and recommendations. So surveillance is obviously key to diagnosing cancer early, and that's always the goal. With genetic testing, if there's a mutation, we obviously have guidelines for the most part that we can follow, but sometimes we're not going to find a positive test result. And in that case, the family history is our guide. And so we will still, in many cases, recommend high-risk screening and surgical intervention when necessary or appropriate. And so we do really go back to the family history often to make those recommendations. For treatment decision-making, again, chemotherapy is one impact, specifically with BRCA. We know that the cancers can be more responsive to platinum-based chemotherapies. And as Dr. Levine alluded to, we can now utilize PARP inhibitors in the ovarian cancer spectrum, but it's also something that they're looking at in breast cancer and pancreatic cancer as well from a clinical trial standpoint. So those are other implications that do apply to people who have testing. So the overall benefits to genetic counseling is that we can demystify the family history. Not every cancer is going to be related to a syndrome or related within the family. So we can kind of help alleviate some of the anxieties that patients may have around a family history of cancer. We can assist with the treatment planning, change management recommendations, and essentially hopefully save lives because we can allow for early screening, surgical intervention, and empowering patients to take action for their own health care. So just quickly around sporadic versus hereditary cancer, of course, most patients that are being referred to genetic counseling have something going on in the family that may suggest that the cancer is hereditary, but most cancer is not. Only about 5 to 10% of cancer really falls into that category. So as a whole, hereditary cancer syndromes are very rare, but we do have guidelines that kind of go broader so we can make sure we're capturing the people that do fall in within that small category. Sporadic cancer, for the most part, is generally most cancer, and that is for a combination of reasons and factors that we do see cancer. And then the familial piece gets a little tricky. We do see many individuals affected, multiple generations, but through genetic testing, we're not able to identify a specific cause. So in those cases, we're left wondering, is there something happening in this family that we just don't have the means to test or offer any kind of insight into? So hereditary cancer, as a rule of thumb, typically will happen earlier than expected. So typically it's under 50. We do expect to see similar or related cancers in multiple generations, and typically on the same side of the family. Individuals diagnosed with more than one cancer, bilateral breast cancer or rare cancer, typically are also on our radar. Rare cancers like ovarian cancer are definitely something that we do want to look out for. Any ovarian cancer at any age, regardless of family history, is a qualifying reason for genetic testing. And so that is one thing that we always encourage people, if there is a family history, to consider having a discussion, not necessarily to do testing, but could have that discussion to see what those benefits and limitations would be for that specific individual and family. And then certain ethnic groups also come into our risk assessment, one being Ashkenazi Jewish individuals because of the higher rate of BRCA. But there are other populations that we do think about when we're offering genetic testing and asking about ancestry. One example would be an individual who's Icelandic or Finnish. So about 25% of ovarian cancer is caused by mutations in a cancer predisposition gene. The majority are in BRCA1 or BRCA2. There are many still that are unknown. And of course, there are other genes that we do know and we can't offer testing for at this time that go broader than just BRCA1 and BRCA2. And about 5% of endometrial cancer is hereditary. Lynch syndrome poses the highest risk and accounts for about 2 to 6% of all endometrial cancer. And it's related to the MMR genes, which are listed there, MLH1, MSH2, MSH6, PMS2, and EpCAM. This graph just kind of breaks down ovarian cancer and uterine cancer related to some of the genes that are known and compares it to the average, which is the far right. And you can see here that uterine cancer with Lynch syndrome has the highest risk compared to any of the other genes. And then ovarian cancer is the highest risk related to BRCA. But we can see that Lynch syndrome also has the risk for ovarian cancer as well. So just to break down BRCA 1 and 2, or BRCA-related hereditary breast and ovarian cancer syndrome, it's probably the most widely known genes, and information within these two genes are the most well established, given that their testing has been around for 20 plus years for these genes. With so much testing and research into it, we do have recent literature that suggests that the breast cancer risk may not be as high as we once thought. It's still significant, but it's not, in the 80s. It's about 45 to 60% lifetime risk. And the male breast cancer risk is about 7%, and it's more associated with BRCA2 than with BRCA1. Ovarian cancer can be up to 50%. The numbers do vary based on what paper you look at, but the main takeaway is that they do have the highest risk right now related to ovarian cancer of the genes that are known. And it does include fallopian tube and peritoneal cancer. So anytime we see a family history of those cancers, it's an indication for potentially testing. And then other cancers related to BRCA 1 and 2 are melanoma, pancreatic cancer, and prostate cancer. Those three cancers listed at the end are more related to BRCA2. The data is still not fully suggesting that BRCA1 has that much of an indication for these three cancers, but regardless, we still manage individuals pretty similar when it comes to BRCA1 and BRCA2, and so I'll go over some of those management options now. So for women, the recommendation is to do self-breast exams starting at 18, and then clinical breast exams starting at 25 every 6 months to 12 months. Annual breast MRI starts around 25 to 29, or based on family history. And then we add mammogram to the MRI around age 30, and that happens until the age of 75 is where the guideline still is cut off. So granted, women are living past 75, so if screening is available, we still recommend that. The option for a risk-reducing bilateral mastectomy is another discussion that we have with women. It's an individualized decision. It's not necessarily a recommendation. We do believe in our screening for breast cancer being really good and able to identify breast cancers early, but many people come to that decision for various reasons, and so it is a pretty long discussion, and one that they have with not only us, but a breast surgeon, just to weigh the options. And it also depends at what age they're coming for testing. As Dr. Levine mentioned, there's really not great screening for ovarian cancer, so the recommendation for women with a BRCA mutation is a little bit more conservative, with the recommendation after childbearing, or ideally between 35 and 40, to consider having the risk-reducing surgery of removing the ovaries and the fallopian tubes. With BRCA2, the data suggests that we can delay that process a bit to about 40 to 45, but that's in cases where there is no family history of ovarian cancer. And for some women, the study of removing the fallopian tubes first can be an option as well. And so we do make referrals to the gynecologic oncology team to have that discussion further. The transvaginal ultrasound and CA-125, again, are options, but they're not ideal, and sometimes patients feel a false sense of reassurance and decide against doing that kind of screening. For men, particularly the BRCA2 carriers, we do recommend self-breast exams and clinical breast exams, generally just around the nipple area where we'd expect to see more of the breast tissue. And then at age 45 is when we would recommend starting screening for prostate cancer. This age was just recently increased. It used to be 40. And so it is a kind of a moving target, and recommendations and guidelines are always evolving. And then for BRCA1 carriers, there can be a consideration for that, or they can just wait until they're 50, or based on family history, if there's a strong family history of prostate cancer. For the melanoma risk, we do talk about, protection, and also recommend speaking with a dermatologist and doing screening every year. And then NYU recently started a pancreatic screening clinic, and so we are referring all patients who are high risk to that clinic so that they can get plugged in and do the screening that they are establishing as a standard. So Lynch syndrome was previously known as hereditary non-polyposis cancer syndrome. The penetrance is fairly high, but there can be variation to that depending on specifics, which I'm not going to get into. But again, it is related to the MMR genes. One other tool that we can use to identify individuals with Lynch syndrome is through tumor testing. So right after someone's diagnosed with a colon cancer and they have surgery or endometrial cancer, the tumor is tested for expression of the proteins related to these genes. If there's any deficiency, then that could be an indication that it's Lynch syndrome. So a referral is made generally to genetics so that we can identify if it's something that's inherent or just present in the tumor. And so that's another way that we can capture patients who might be lost, because the guidelines for Lynch syndrome for testing tend to be a little bit more complex, and this screening of the tumor can sometimes alleviate some of those issues that we run into. So Lynch syndrome accounts for about 2 to 3% of all colorectal cancer and about 2 to 5% of endometrial cancer. We can see early ages of diagnosis and variability as well. And most cancer in this case is going to happen on the right side of the colon. So that's usually a consideration we ask, if there's a colon cancer history, do you know what side it was? Is there any indication that you know if it was on the right side? Colon cancer risk is high for both men and women, but it tends to be much higher for men. And we can see some of the other cancers here listed. And so those are always on our differential when we're taking a family history, so that if there is a case where there's biliary tract cancer, we can identify those patients. And this is just comparing men and women to the general population. Of course, men can't get ovarian cancer or uterine cancer, but we see here that men have the highest risk for colon cancer. And for women, uterine cancer and colon cancer tends to be pretty much the same risk. And so sometimes a gynecologic cancer may be a woman's first cancer with Lynch syndrome. And so it's always good to just know the family history and to get them connected when necessary for potentially a discussion around testing. So screening for Lynch syndrome, when it comes to endometrial and ovarian cancer, we are limited with what we can do. Women can do biopsies every 1 to 2 years, but again, it's been shown that the screening for individuals with Lynch syndrome is not that beneficial. So we do discuss a full hysterectomy in this case after childbearing. And again, we run into the risks with ovarian cancer as well in the limited screening. So for patients with Lynch syndrome and BRCA for that matter, we do generally refer to our gynecologic oncology team so that they can have a more thorough discussion just related to their history and not make a case-by-case decision. But the recommendations currently are to have a hysterectomy just to reduce that overall risk, because it's the best and only option that we have at this point. And then colonoscopies for Lynch syndrome do start much earlier than the average person. Typically, we're starting them at 50. With Lynch syndrome, we are going to start them around 20 to 25 and do them every 1 to 2 years. Or 2 to 5 years prior to the earliest colon cancer diagnosis if it did happen earlier. So it's a disease that is difficult and does impact people significantly, and so we do spend a lot of time around the information pertinent to that. And I won't go into the other screenings, but there are other things related to family history and if we see some of the other cancers related to Lynch syndrome. So as I mentioned, genetic testing has evolved, and we used to start out doing single gene testing. We can still do that, and of course there's panels. So single gene is looking at things one at a time, or panels looking at multiple things. So if you see here, we know that there's many genes related to ovarian cancer, and there's many genes related to endometrial cancer. There's overlap between the two types of cancers, between the genes that someone could have. And so in the past, it was really difficult to know where to start. We always will start with BRCA1 and 2 because they will pose the highest risk and maybe are the most likely. But depending on the pathology of the ovarian cancer or even endometrial cancer, we might have a different and the family history. We might start with Lynch, for example, or in many cases, we can just start with a panel. So we can get the answer at one time. It's a faster turnaround time. Cost is generally also cheaper, and so it allows for a benefit. Now, obviously, there's limitations to both approaches, and so we do discuss those with patients and benefits. So it's kind of really laying down what the pros and cons are of the different ways of doing testing. I would say as a whole, most of the patients now, though, are doing panels just because they're available, and we know that we can pick up things that maybe were missed in the past when the testing was not this robust. And through panels and the research in the field, we also know of three new considered high-risk genes related to ovarian cancer. They are BRIP1, RAD51C, and RAD51D. All three of these, in addition to the Lynch syndrome genes in BRCA1 and BRCA2, do have a recommendation or consideration for a risk-reducing surgery for the ovaries and fallopian tubes. And so this is a discussion that we have with patients if any of these three mutations come back as a positive test result. There's no way for us to predict the chance that someone would have a mutation in one of those three genes. So sometimes it is counseling around the chance that it might be something unrelated to what we're expecting. And the lifetime risks are into parentheses, but those are kind of moving targets as these are newer genes, so there could be a change in that overall risk with time. Reproductive options do come up pretty frequently as well, as most of our patients are young and are wanting to know what the next steps are, either for their own children or for future childbearing, for their childbearing years. So one option and these are in no particular order, and everyone may have a different way that they would order these, so this is just listed out, but natural conception with no additional testing prenatally or before pregnancy is one option. Prenatal diagnosis can be available, though it is kind of complicated and not all labs will do it, as most of these cancer syndromes are adult onset. Testing for carrier status is generally not done in minors, though there can be exceptions that are made. Pre-implantation genetic diagnosis is another option that's available. It does involve IVF, so it is creating an embryo and then testing the embryo, and any embryo that is affected by the mutation is not transferred or used for pregnancy. Fertility preservation is also an option. So for our younger women who are not ready to have children but are finding out that they are mutation positive, they have the option to freeze their eggs before undergoing one of those surgeries. And then there's the option, of course, of donor egg, donor sperm, and adoption. So in summary, the family history is an essential tool. We use it for many avenues of testing and also recommendations for screening and management. Criteria is specific for different tests and dependent on what kind of testing we offer, and also to identify the best testable person. BRCA, yes, it's related to breast cancer, but it can also be related to ovarian cancer. And Lynch syndrome may have a higher risk for endometrial and ovarian cancer than the average and may present that way in women before it does with colon cancer. So it's one to just keep on the radar. And genetic testing can impact the clinical management and effect of affected and unaffected individuals, and with that can bring a lot of psychosocial concerns, and so there's a lot of support that we provide in that sense as well. And given that there's many genes now available for testing, we're always kind of keeping up with the data and making sure that we're keeping up with the guidelines and offering the proper management based on that evolution. So these are just some supportive services. You don't need to memorize them. If you have specific questions, you can always email me with that. TEAL is a new organization related to ovarian cancer, and they're having a walk on Saturday if anyone's interested. And FORCE is for women who have, and men who have BRCA mutations. And I thank you.